Hello, everyone. It's me again, Marty Ross. Welcome to another Conversations with Marty Ross MD tonight. So the format for how these Zoom Room webinars are working is that you need to write your question to me, and the way that you do that is over in the chat box. So just click on the chat box and write the questions that you want me to focus on. I'll be glad to do that. And then if the questions require some clarification from me or I want to get your input, then I'll ask you directly to turn your camera on and turn your microphone on so I can talk with you directly about what it is we're discussing. All right. And then the other thing I'd ask, because I'm relying on the chat box to see questions that you have, I'm going to request that you don't actually try to do chats back and forth with each other in the chat box, because it will clog up my screen. It'll make it harder for me to follow the actual questions here, okay? All right, so that's just the request I have. When you write your question, I'm going to ask that you post it to everyone so that everyone can see it. And as I'm going through those questions, they'll be able to read through those as well too, okay? All right. So I know we had about 90 people or so signed up for tonight. Usually there's a lot more people that sign up than are here. Right now, I think we've got about 21 or 22 people here at this point. So we'll see how this all goes. And I'll talk for as long as you have questions or until an hour and a half from now. All right. So without any further ado, oh, one last thing. I am recording this again tonight. And then tomorrow morning, look over in the Zoom Rooms recording. On the left-hand navigation at Lyme United, there's something called Zoom recordings. Look there for the recording of this. You should get notification when that recording is ready. And I also have been creating a summary of those recordings. And if you actually hover over the recording, you can see where the chapters or the summary are tied to certain parts of the video. So it makes it easier for you to be able to skip through the video to see what it is you're trying to look at. Okay. All right. So without any further ado, let's go ahead and get started here. Anne says hi. Hi, Anne. Good to see you there. And then somebody else said hi. Zoo said hi. I don't know who Zoo is. And then here's our first question. So this is from Gal Reagan. Gail says, my LabCorp intrinsic factor antibody was 1.2, normal is 0 to 1.1. And my antiparietal cell antibody was elevated at 36.4. Normal is below 10. But my B12 and folate levels are okay. Also, my MCV is sometimes elevated, but like 1 to 2 above normal over the years when I have had a CBC done. My L&D wants me to do methylcobalamin sub-Q injections 1 to 3 times per week for the next 6 to 9 months. Do you agree with treating me for pernicious anemia based on these labs? Let me just see here. Let me relook at this again. So, Gail, can you let's see, Gail, can you let me know, do you know what your actual B12 level is?
I haven't done this format with you before. Sorry, I've always done the other kind.
Yeah.
Do you want me to actually, I mean, I don't know how much time, I don't. I'd have to
Okay.
like look.
Well, let me
I'd have
just
to
ask
go
you
log
this.
into LabCorp and look, and I don't want to take your time. But it was like right kind of in the middle. It wasn't
Oh, it's in
high.
the middle. Okay, so it's not sitting at the bottom. It is
Yeah,
solidly in the middle then,
I think
basically.
it's in the
Okay.
middle. Yeah.
Okay. So, to answer your question there, so your the way that B12 gets absorbed is that when we take it orally, goes into the stomach, and in the stomach there's a protein called intrinsic factor that binds to the B12. The B12 bound to intrinsic factor floats downstream into the intestines where it gets absorbed. The cells that actually make those that intrinsic factor are the parietal cells. And so it's concerning that you have antibodies against the parietal cells. However, it doesn't appear, because you have normal B12, you're making adequate intrinsic factor. The only way you could be getting your B12 absorbed is if you're having adequate intrinsic factor. And in fact, I think there's actually a way you can measure intrinsic factor too. You don't have to just do the antibody levels here. So putting that all together, because you have very normal B12 levels, even though you're having an immune reaction against your parietal cells, it looks like they're working well enough to make that intrinsic factor, basically. Okay. Let's see. I'm just muting somebody here. There, I just muted one of our members who I think we were hearing them as background. So I don't think I would be doing those B12 injections. And I think what she's doing is she's treating a lab, meaning the antibodies, but I would not do that with, I would not give B12 unless there was evidence of B12 deficiency. And the fact that your normal B12 says you don't have deficient levels, a blood cell size, that MCV, if it's very large, that sometimes can be due to B12 being low or folate being deficient. But if it's only 1 or 2 above normal, that's not enough to say that you have the problem either. So on the whole, my opinion would be don't do the B12. But again, I'm not your physician. I don't know everything going on with you too. So yeah.
Okay. Are these back and forth, or is that we just stop there with this kind of
No,
format?
if you want to do a follow-up,
Oh,
feel free.
I just want, you
That's what
mentioned
makes
there's
this all
another
good.
Okay, you mentioned there's another test you can do to further look at the, I don't know if you said it was the intrinsic factor antibodies or the anti-peritoneal cells. What was that other lab?
I think you can measure intrinsic factor directly, or you can measure intrinsic factor antibodies. I'd have to look and see for
Okay.
sure, but
Well, I'm seeing a hematologist,
yeah,
primary care doctor, so he's going to probably know all that. And but my Lyme doctor said, oh, the hematologist probably won't want to treat you because your B12 levels are normal, but he sort of seemed to indicate that's like, you don't actually know how much level, like cellular level
yeah.
B12, like how much the cells are absorbing. I don't know.
I think they're overreading it personally.
Okay.
Yeah. So the other
Okay.
thing you can measure to even see if you're okay too. So there's B12, and then there's another metabolite called methylmalonic acid
Oh, he
that
tested that. That was tested.
was it normal?
Yeah.
Yeah, you're fine. You're getting plenty of B12 in you then.
Okay. Okay.
Yeah. Okay.
All right. Thank you.
Yeah, good luck.
Thanks.
All right, let's see here. Okay, this is from Mega Awesome AGT, whoever Mega Awesome is. I like that name. That's good. Let's see here. What's going on? Oops. I don't know how somebody's whiteboard showed up there, but I just got rid of it. Anyhow, so here's the question. It says, "Hi, Dr. Ross. I have a 9-year-old, 60 pounds with Lyme, Bartonella, Babesia rickettsia, and treatment from 3 years now. He is currently on clarithromycin, fluconazole, 3 days on, 1 day off, Japanese knotweed, cryptolepis. Our issue is that the herbs are not enough to hold him from flaring. But when we add a second antibiotic for Bartonella like fluconazole above, his vision symptoms get really bad. His eyes become very red, more light sensitive, hurt, eyeballs start swinging but involuntarily, intermittently through the day, and it continues for several weeks, even if we stop that antibiotic. This is not letting us progress in our treatment and don't know how to cross this hump. For example, we started fluconazole 2 months back, and we are still not on a once-a-day dosage yet. Our doctor wants to add Baluchi and methylene blue drops next, but he and I are both worried because he hardly handles anything. Okay. So let me try to make a few comments here. So when somebody has a lot of sensitivity, whether it's reactions like strong Herxheimer reactions, which is kind of what this sounds like. So whenever you start killing germs, your immune system will see the dead bug parts and make more of those inflammation cytokines that many of you know I talk about. So cytokines are chemicals made by white blood cells that help them fight infections, but in tick-borne infections and in mold toxicity, the immune system makes excess amounts of these cytokines. And then when you start killing germs, it even makes more cytokines. And those cytokines can lead to a lot of these, what we call Herx symptoms, including neurologic agitation, which is what this eye symptoms sound like. And so it sounds like it's a strong Herx. So when we do treat people, we want to make sure that they have adequate levels of a drug in them to kill the germs, okay? And there are ideal doses that we try to go for, but what really determines what is effective is, do you have enough in the blood? And what determines do you have enough in the blood is how much do you take and how effective are your detox mechanisms at cleaning that drug out. And what I believe is that when people are very sensitive to medicines, a part of that is their detoxing of the drugs out doesn't work as well. So therefore, to keep an adequate level in the blood, you don't necessarily need to put as much in because they're not cleaning it out as fast. Okay. So I would not, in a situation like you've just described, I would not get so hung up on, are you up to the adequate amount of the drug? I would just be working with the amounts that can be tolerated. That's what I would work with. As an example, I once managed somebody with Bartonella and Borrelia that lived in Canada, and we were able to get up to 1 to 2 drops twice a day of 4 different antibiotic herbs. We could never get above that. And many of you know with my antibiotic herbs, generally, except for the cryptolepis, most of them I'm going to dose at 30 drops twice a day in adult. And this is an adult that I was only able to get up to 1 to 2 drops twice a day of 4 different herbal antibiotics. And she got 100% well. And it's because anytime we went above that level, she got floored with side effects, with Herxheimer reaction symptoms. But as long as I stayed under that level, she was able slowly to move forward and she got adequate killing because probably her detox mechanisms were so messed up that she couldn't clean out the drugs and she was having an adequate level. Okay. All right. So the reason I say all that is if his treatment is moving forward on the clarithromycin, 250 milligrams twice, and fluconazole 50 milligrams once a day, 3 days on, 1 day off, and the knotweed at 30 drops twice a day, and the crypto at 25 drops twice a day, that may be all you're going to be able to do. And that may be effective dosing for you. Okay. All right. So let me read back here for a minute. Oh, okay. So the herbs don't hold them from flaring. I got that. All right. The one thing you might want to consider doing with that fluconazole is you could even consider, instead of doing 50 milligrams once a day, you might even consider backing down to 25 milligrams once a day and staying on it continuously. I admit that's a lower dose, but that might be an adequate dose, for him, basically. Okay, all right. And then you know, so what I can't tell from this question is, can you tell me, is he getting any better on that at all or not?
So yeah, hi, Dr. Ross.
Yeah.
Yeah,
Okay.
hi. Sorry about the name. My son put it
That's
Meadows.
fine. That's perfectly fine. Yeah.
So yeah, he's getting better, but he only ever reaches this plateau where he just gets better this much.
Yeah.
And if we don't increase the dosages, it's only until the next flare that he goes all the way back.
Yeah. Yeah.
So we have to like continuously keep increasing as well.
Yeah.
But whenever we go on the second antibiotic, which is fluconazole or rifampin, which basically hits Bartonella, his
Yeah.
eyes get really bad, and that prevents us from going further.
Yeah.
He doesn't have a lot of other herxes. Basically, everything around his eyes is the biggest challenge for us. His doctor thinks that maybe there are a lot of biofilms in the eyes, and that's why he wants to add Beluki.
Well, so I want to make sure I understand. So this regimen of clarithromycin, fluconazole, knotweed, and crypto, he still is gradually improving on that. Did I understand you correctly with that?
Yes,
Okay.
he has improved on it.
Yeah, you may, so if that regimen is gradually improving him, I would probably stay on those as your main antibiotics.
Okay.
But you might back down on that fluconazole just so that he doesn't flare at all on it, basically. There is one thing I do think you should add. I don't necessarily think you necessarily need to go to methylene blue. You might go to the Beluki next, but here's why. So there's a couple reasons to do that with Bartonella especially. So we increasingly are thinking that one of the reasons Bartonella is hard to get rid of is that there are biofilm slimes that grow over the germ, not just in the eyes, but anywhere, okay? and that unless you start clearing some of that biofilm away, you're not going to get adequate killing of the germs, full killing of the germs, basically, right? So that's one thing. Secondly, separate from, so what a biofilm is, it's a mucus slime layer that germs create. And this mucus slime layer is complex. It has this sugar slime, and the sugar slime is held together in a protein skeleton made up of blood clotting protein called fibrin. Within that biofilm, there's all kinds of different bacterias that are not Bartonella, that are other germs that live there. Each of those germs have certain functions. There's like a group of them that organize the post office. Some of them are the grocery store. Some of them are the sanitation department. I hope you get my analogies here, but they all have functions. Okay, these are complex structures, all right? All right, but when you use a lumbrokinase, what that does, Bolucki lumbrokinase, is it breaks down the fibrin, which helps this whole thing to fall apart, okay? Now, there's a second thing that happens in Bartonella, separate from biofilms, is that we think that the Bartonella germs have the ability to wrap themselves in fibrin, and they have these little clusters of fibrin and germs that also, that fibrin kind, and then they stick themselves on blood vessel walls and they wall themselves off. So the lumbrokinase does two things for you. It helps start breaking down some of that biofilm, and in addition, it helps break down the fibrin in these fibrin germ clusters, basically, too. Okay. And I would, given his reactivity, I'd probably go very slow with how you add that in. You might even look at opening up the pill and starting maybe at half a capsule, even every other day, for instance. Okay. And just gradually step into that. But that's probably how I would approach that.
Okay. So I would hold on methylene blue for now, and then maybe lower the dose of fluconazole, make it a consistent everyday dose, and add Bolucki.
Yeah, see about that. I mean, it's a teeter-totter. The main thing is you just want to make sure he's going forward overall, and it sounds like he is. And the other point I'm trying to make here is I wouldn't get so hung up on hitting the top dose, because it may be for him, his detox mechanisms for fluconazole aren't allowing him to clean it out well enough. So therefore, you don't need to go as high of a dose. That's the main concept I wanted you to know about that too. Okay. All right.
Yeah. One more just question about him, Dr. Ross. Like in his recent blood tests, recently we were talking to someone about the B12 levels. His B12 levels have been double of the higher upper limit. Does this have anything on how he detoxes or any bearing on it?
I don't see a harm to having too high of B12 levels, to be honest with you. So I usually don't do anything about that.
Okay.
Okay.
All right. Thank you so much, Dr. Ross.
You're welcome. And then Tracy, I see your hand up here. I'm assuming it relates to this question here.
Yeah, I was just wondering if you're not gonna increase dosage, if there might be any benefit to adding like an arterosil or something to help better deliver the dosage to tissue, if there's any kind of problem with the glycocalyx.
So everyone, so arterosil, so one of the things that may happen in Bartonella, although we have no lab evidence of this, I want to be clear about this, okay? But Bartonella infects the endothelial cells that line your blood vessels. And overlying the endothelia, these blood vessels, is something called the endothelial glycocalyx. And the endothelial glycocalyx is responsible, if it's functioning properly, for helping to absorb things into the cells, but also releasing nitric oxide. And nitric oxide then causes your blood vessels to dilate further downstream, so you get better blood flow of the antibiotics. And that's what Tracy is describing here, right? And I do think, so there are times I think that it's a good idea to add in arterosil into a treatment. It's a ramen sulfate mushroom mix, basically, that has been shown to have activity of rebuilding the endothelial glycocalyx. All right. But when I'm thinking of adding that in is usually I'm going to want to get somebody stable on an antibiotic regimen that's moving them forward. I might go for the Bolucki next. And then if they're stable on that, I might think about trying to see if working to fix the glycocalyx is going to help. And the reason I stage it that way is what I'm doing is killing a little bit first. We remove biofilms, that kills a little bit more. So you're trying to temper your Herx reactions. And then opening up your blood vessels even more, you're going to get more killing. So I'm just trying to stage how you wind up going about Herxing and all that as well too. Okay. All right. Tracy, did that answer your question too?
Totally. That makes so much sense. Thank you.
Yeah. It's just a matter of staging things, basically. Yeah.
Mhm.
Yeah. And then Athena, I saw your hand up too. Is it still up? Yeah, there it is. Yeah, Athena.
It was actually a comment on the B12, but before that, when you mentioned staging, do you mean to say that there's a duration of time to ensure stability before anything exacerbates things too much? Is that part of the staging?
You know, so staging is kind of an art, and meaning you have to be careful with how much of a Herx you get in some people. There are some people that you can dump everything into them and they never will Herx. There, in my experience, there's about 15 to 20% of people I treated for tick-borne infections that never Herxed at all. Okay, that's possible. Those people, it's kind of hard to be in a treatment because they don't have any proof that anything is working. And as many of you know, sometimes with Borrelia Lyme, it takes 6 to 9 months before you even start seeing improvement. So when you don't Herx, on the one hand, that's a blessing. On the other hand, you just don't quite know if it's working, especially if you're not having any improvements, okay? But we also have to be careful on the other side as people that Herx a lot. And if you get too many cytokines, you can actually cause neurologic damage. You can get damage to the tissues, actually, right? So it's a teeter-totter. And there's not a right progression, but there is a progression where you're trying to balance that you don't clobber somebody too much, basically, because you have to keep in mind that too many cytokines, really knocking somebody down bad, could result in damage. So it's when I'm treating somebody, I'm trying to be careful. I'm working with that teeter-totter. I'll let them Herx to a degree, but I don't want to clobber somebody too much because you could get into some injury for it, basically. And so as part of that, trying to make sure you don't over clobber with cytokines, I try to gradually stage how I'm adding things into a treatment, basically.
Okay, thank you. And then just the second comment on the B12 discussion. I
Yeah.
didn't realize, I only realized as a consequence of genetic testing that I had done initially that there is a gene where the B12 reading is completely off because of the way you metabolize it. So it can say you're thousands higher in the range than you are, but it's of no concern. So that was kind of a learning curve. That the B12 reading was really not, I don't want to say not relevant, but maybe not precise or accurate.
Right.
So the reading doesn't reflect what's actually going on.
I think what's important with B12 is, do you have enough? Because if you don't have enough, it does affect neurologic function. If you don't have enough, you may get pernicious anemia from that. But having too much, I'm not aware of any health problems that develop from having too much.
Yeah, I'm actually, thank you for clarifying. I'm actually thinking of the scenario where you're thousands higher, too high, but the way you metabolize it, the reading is not really thousands too high, and you can
Got
still
it.
supplement with B12. So that was
That's-
kind of confusing when I first had a learning curve with that,
Yeah.
because I was supplementing with B12, but my numbers were so high.
Yeah.
Yeah,
Yeah. Thanks for making that point.
thank you.
All right. All right. So let's move on here then. Let's see here. Okay, next one is from Lisa. Hi, Lisa. Let's see. I have a question about the AccuDart results versus Argenx immunoblot test and culture test. Yeah. So the AccuDart, everyone. So at the recent ILADS meeting, what, 2 weeks ago now almost, IGeneX was there, and they finally were able to tell us that actually AccuDart is their test. So, and it's really kind of a tricky thing. I was really confused on that. I don't think they've done a good job of explaining what the heck they're doing with this AccuDart, just so you know. Okay, so there's IGeneX, and then for their more commercial products, they've created, I believe, another legal arm that's under the IGeneX umbrella. And that is that other company or part of their company. I think I think IGeneX is the corporation, and they have their regular lab, and then the other companies that sell commercial stuff is another business arm. And out of that, you're seeing this test called AccuDart, and you're also seeing another test called iDart. Okay. Now, if you listened in on the webinar last week, you saw that I talked about the significance of this new iDart, which is they finally have gotten FDA approval to sell their test kit to other labs. And their test kit is approved right now for their IgG immunoblot, meaning they sell it to Pack Lab or LabCorp or Quest. And Pack Lab or Quest or LabCorp can run this test, which uses the IGeneX immunoblot method in their own lab. And so what's significant about that is for the first time, the FDA approved the IGeneX diagnostic criterion on the Lyme immunoblot, okay? Which means that we now look at, the 6 important proteins, 23, 25, 31, 34, 39, 41, and 83, 93. And we can decide if somebody's positive just looking at those 6 proteins, not the ones that they've told us to use before. And because those 6 proteins having antibodies against 2 is so strong, you don't need to do what's called a 2-step test either. So you don't need to do this ELISA test that they said you had to pass first before you go to the Western blot. This is a 1-step test. So what's significant about the iDart is they recognize the IGeneX diagnostic criterion, first time that the FDA has done that. Secondly, it's a 1-step test, okay? But it's only approved for the Lyme Borrelia, that is Borrelia IgG. The IgM test probably is going to be approved here soon. Okay, all right. Then IGeneX then also has this other test company called AccuDart. And AccuDart is an at-home test or an at-home collection that you still have to send off to IGeneX. But it uses a small prick blood that you put on, I think, a collection, like something you smear it on, basically. It dries, and then you send it off to IGeneX, okay? And it is going to be, my understanding is available for Borrelia, Bartonella, Babesia, I think is for all of those, okay? But the significance is they were originally saying that it was as accurate as their immunoblot that they run in-house. And I challenged them on it. And I said, that makes no sense. I said, because their immunoblot, which is 94% sensitive, meaning it can find the infections if you have it, if it's there 94% of the time, that's on whole blood that's drawn from your arm, a big volume of blood, okay? The fact when you're doing a small prick, you have less volume, that's going to tend to lead to more errors. And so when I pushed them on it, they said, "Oh, that's right. We've had to correct it." So what their information now says is that the AccuDart is 83% sensitive. All right.
I'm sorry. If you don't mind, I'd like to share my own experience because
yeah, go ahead.
So this is all about my daughter again. So we did the full workup, probably $2,500 tests with the fish, with the GMA, with the immunoblot, so on and so on and so forth for all the co-infections and Lyme. And then a second doctor did just the culture, which I guess is the enhanced PCR test.
Yeah.
I also did Infectolab.
Mm-hmm.
From one of the same doctors. And then finally, just recently, the AccuDart. I thought, because these other tests, some of them are a year old, but she really didn't have any treatment.
So did the AccuDart go positive and the other ones were not?
The AccuDart was negative across the board. Now, with the full-on, I'll call it the full-on IGeneX, where they draw a lot of blood, and also to just an interesting point, I think the AccuDart results were back in 2 or 3 days.
Yeah.
Really.
It's fast.
But they were all negative. But when we did the other tests, she came back with a positive PCR for Babesia. For the other one, she had a positive band in Borrelia. She had positive TBRF. detected 2 or more TBRF Borrelia species, and it was the Borrelia SPP.
Yeah.
And then the Babesia in the fish, it was positive, and IgM as well. My
Right.
question is, but then I did the AccuDart and everything was negative.
Yeah. So the AccuDart will miss it more than those other tests do. So the AccuDart, when we say something, so in medicine, we recognize in looking at tests, we look to see if how sensitive a test is at finding an infection. And sensitivity means how often when the infection is there, will it detect it. So AccuDart is only 83% sensitive, right?
And you said it's IgG though, right? The AccuDart is IgG. So
AccuDart is either IgM or IgG. They don't distinguish, but they're testing for both. But excuse me, IgG and IgM antibodies, it's a yes/no response you get. They don't tell you which bands, they don't tell you which antibodies. It's just a quick and dirty yes/no test, basically. Hold on here just a minute.
sure. Yeah, I just thought that was
so it's not as accurate at finding it. However, what is good about this test is that it gives the ability for people to go around their doctors and test at home themselves. So, because the medical establishment still is stuck on doing the two-step test, which misses Lyme if it's there 50% of the time. So the AccuDart, compared to the way that most doctors are going to test you, is still more sensitive, a lot more sensitive. Okay. And so, but if somebody gets a negative AccuDart and they're still concerned about having tick-borne infections, then they should proceed probably with doing the immunoblot methodology or other methodologies that are out there. But as a quick and dirty test that can give people some pretty quick information that might get their doctors to treat them sooner, the AccuDart's not a bad way of going, recognizing it's wrong at finding it 17% of the time.
yeah. Okay.
Yeah.
It just rocked my world a little bit because I thought maybe is it mold illness? Is it toxic mold illness? Like what, I started to question the big hefty test.
Yeah. So the big test there that you have, so let me just do a quick testing discussion here. So in testing, we have what are known as indirect test and direct test, okay? Direct test means you can actually see parts of the germ. You're looking for parts of the germ. An indirect test is you're looking for the immune system reaction against the germ, okay? All right, now direct tests are cultures. They're also looking for the DNA of the germ in your blood using a methodology called PCR. They're FISH tests where we take a fluorescent marker that attaches to the genetic material of the germ so we can see it under a microscope. Those are all direct tests. The indirect tests would be your immunoblots, which are antibody testing. They would be your ELISpots, which are looking to see if you have reactivity of your white blood cell, T white blood cells. All right. All right. Now, the thing that's good about the direct test is if they're positive, it's irrefutable. It's in you. All right.
Yeah.
They're really good. When they're positive, all right. However, because these germs are not readily living in the blood when you draw it, it's hard to say what the sensitivity is for the direct test. In fact, Galaxy, which runs one of the Bartonella direct test, and even IGeneX on its new enhanced PCR culture test, they don't have any data that tells us what the sensitivity is. They don't know. They actually don't know. Okay. All right. Versus there is good data, especially on the immunoblots through IGeneX, that they are 94% sensitive and their AccuDart is 83% sensitive. So at least we know what the sensitivity is there, basically. And so that's why in my articles that I write about testing, I usually advocate the immunoblot method first. The problem with the ELISpot methods that are being done out there is, in general, ELISpots, when you look at the science on this, ELISpots are about 85% sensitive. The problem, if you're for the germ that you have there, will only find it 85% of the time. The problem is Infectolab and Armin labs that do the ELISpot testing are not testing for all strains of the germs that people have. So,
Yeah.
it might be that their sensitivity is 85% for Borrelia burgdorferi, but what if you have one of the other Borrelias that they're not testing for, right? And that's the only problem why I don't suggest people do ELISpot testing up front, basically. Yeah.
Okay. Thank you
Right.
for.
Yeah, no problem. All right, let's see here. Does anyone have any other comments about that before I move on here? All right, let's see here. Hi, Bob. Let's see. It seems that many MCAS symptoms overlap with Lyme symptoms. If we cannot trust Lyme disease testing, how can we differentiate? Let's see. Bob, I'm going to just I'm going to mute you just for a second because there's some buzz coming through your microphone there. There we go. So let's see, if we cannot trust Lyme disease testing, how can we differentiate? I've interfaced with several Lyme-related souls that also have MCAS issues. It would seem that perhaps Lyme can bring on MCAS issues, but the original question still is a problem. Is it MCAS or Lyme? Okay, great question, Bob. So here's the thing. So what we know about MCAS, how mast cell activation syndrome occurs is something's got to juice and turn on those mast cells. All right. So your mast cells, everyone, are your, I'll call it the allergic reaction cell. That's at least when I went to medical school eons ago, like over 30 years ago. I think it has been that long. Yeah, about that long ago. We learned that mast cells were only involved in classic allergies like pollen allergies, bee sting allergies, okay? And the model that we were taught is basically your mast cells, something you're allergic to gets bound up by a type of antibody called IgE. The IgE, with that thing you're allergic to, lands on a mast cell, attaches, and causes the mast cell to spit out all kinds of histamines, and you get that full allergic reaction that people get, okay? Subsequently, though, there's been a lot more work done. And now what we know is the mast cells get turned on by a lot of stuff. They get turned on by mold toxicity. They get turned on by chronic infections. They get turned on by stress and how you handle stress. There's all this stuff that turns them on. And what we have seen with a lot of people is usually when people first enter Lyme disease, there isn't anything that suggests mast cell. But often as we treat, the longer their bodies are being turned on, their mast cells are turned on by the infections or these toxic chemicals we have to give you to kill the germs or mold toxicity, then mast cells activation can sometimes start popping up. So usually by taking a history, you can kind of figure out what came first, but usually it's infection or toxicity that comes first. At a point, though, the mast cells do get activated, and it's tricky to figure out. I agree with you. What makes it tricky is we don't have good testing to tell if your mast cells are turned on. We have testing we can do, but it's not 100% accurate. So it's more of a clinical sense. And the clinical sense that we look at is if I've been treating somebody and suddenly they start becoming very reactive, I'm thinking the mast cells probably got turned on, okay? Or they start developing a lot of food allergies, I'm thinking the mast cells got turned on. Or they start having problems with a lot of hives, or they start getting a lot of asthma. We start seeing allergic, quote unquote, conditions, I'm thinking the mast cells got turned on. So it's more how you figure it out, it might be there is based on the history, but usually what comes first is mold toxicity, tick-borne infection, stress that juice up the mast cells, and then you start having problems with the mast cell activation down the road. Yeah. Bob, did that answer your question for you? Oh, I'm sorry. Now we're going to have you turn the microphone on. I'm sorry about that. There you go. Bob, Bob, I'm sorry. Bob, I'm sorry. Your mic, for some reason, the way your sound is being transmitted to us, you sound like a high-speed Donald Duck, and I cannot make out what you're saying. I apologize for that. I don't know what's happening with the interface between your microphone. Are you using a microphone that is in your computer, or is it a separate microphone? If it's a separate microphone, you might want to try to unplug it and then see what the computer microphone does. So so if you just did that, go ahead and unmute yourself and let's see if we can hear you now. Say something. Oh, yeah, say something now, Bob.
Hello, hello.
There you go. You're not Donald Duck. That's good.
Well, yeah, my audio device and my camera are all the one same device.
Yeah, got it. Got it.
But it looked like it was a configuration problem. Anyway, the doctor I'm working with is, we've been treating for Lyme and Babesia for a while, but I'm just super sensitive to just so much stuff. It's become unbelievable.
Yeah.
And now we think there's some mast cell issues going on, and unfortunately, there's really no good treatment for mast cells either, other than, stay away from the things that cause it.
Yeah. Well, there are some things you can do. So a couple things that I would point out. So when somebody starts getting really sensitive and reacting to things, I do think mast cells are turned on. But what I have learned, though, is usually what the cause of that is having been on all these antibiotics, you can trigger too many yeast to start growing in the intestines. All right. So often, if you start getting reactive to all kinds of things, if you start looking to see if you might have yeast, and that is based on symptoms. So if you've developed a lot of increased sugar cravings, if you become sugar sensitive, meaning you crash when you have sugar, if you are having a lot of increased gassiness and bloating, if you've had worsened skin conditions, skin will get worse if you have too many intestinal yeast. But if you have a number of those symptoms suggesting increased intestinal yeast, I would focus on treating the intestinal yeast, because that may be what more acutely is juicing your mast cells. And usually, if you focus on that for about a month or two, getting intestinal yeast under control, those mast cells will quiet down pretty quickly. Okay.
Okay. All right.
And then the second thing is, take a look, I have a whole article I'll show you here in a minute on mast cell activation. And there are some basic things to do. One is de-stress, try to get rid of stress as much as you can. Number two, be on quercetin to stabilize your mast cells. And that would be at least 500 milligrams twice a day. Okay. Number three, consider adding in an antihistamine like Zyrtec, and you take it one time a day. And these are things you can do to help control until your mast cells quiet down. You get either the yeast out or your toxins out, so things get better. Okay. So there's just some basic steps, but I can show you that whole article to take a look at.
I think I've read it. Unfortunately, believe it or not, I react to quercetin too.
To which one?
Quercetin.
Oh, you did? Okay. Then you might.
I struggle taking quercetin too.
Yeah. You might look at, now I don't have a source of it at my store, but luteolin, I have a source of luteolin, but it has quercetin in it.
I have experimented.
Pure
luteolin. The problem is, it seems like the only dosages you can get there, you have to take a liposomal version.
Yeah.
I'd have to find somebody to start with a really small dose.
Yeah.
I haven't been able to find it yet, but I'm
okay.
But when I am tackling the problem a weird way, if you will.
Yeah.
It's like, okay, what things stabilize mast cells? And there's some oddball things like valerian root and lemon balm, and believe it or not, benzodiazepines. There's a number of mast cell stabilizers, which I'm trying to work that way for now.
Well, one other one you might want to consider, it has both mast cell stabilizing effects as well as antihistamines effects, is to do, oh no, I'm gonna blank. Starts with a K.
Ketotifen?
Yeah, ketotifen. Thank you. Ketotifen. Yeah.
Yeah.
Yeah. Because it hits both sides on that.
I use some ketotifen for it's a cure for insomnia for me.
Oh, really?
Oh yeah, I take it once in a while to sleep because I struggle sleeping wise too.
Yeah.
And one of the one of the things that drives insomnia is too much histamine from mast cells. Like that's what keeps you awake, histamine.
Yeah. Yeah.
And I struggle with that. So once in a while I'll take ketotifen. The problem is, this is the other weird reaction. You're going to laugh when you hear this one. Is when I take something and I stop, I get what I call the hangover effect. It's like it's like all of a sudden now it's got to make up for lost time.
Yeah. Yeah.
So,
No, it does sound like you've got mast cell activation. I mean, and it's tricky finding the drug combination that's going to work for you. I get that. All right. But the one thing that I would say, if you haven't considered intestinal yeast being partly under that, that can give some pretty quick resolution.
I'm glad you mentioned it.
Okay.
I have not, and I will bring that up with my doctor. I see him in a couple of weeks.
Good.
We're off on a couple other tangents too, but there's so many MCAS symptoms that match Lyme disease symptoms very closely. It's like,
no, that's what I said. That's why you got to kind of take the history and try to figure out what came first. But usually, usually reactivity means that you've got MCAS on top of your infections.
And to be honest with you, Marty, I'm not sure I could tell you what came first here.
Yeah,
I would struggle with that. I've been dealing with this problem for a few years now, and
I think in my opinion, it's usually the tick-borne infections and or the toxicity that came first. You've got to have something that juices them.
I read that too, but I will pursue the intestinal yeast thing. I mean, you know, there's another. You ever get that feeling that there's a missing link somewhere yet?
Yeah. Oh yeah, I get it. No, but I can also, I'm sharing with you my experiences. Often that is the missing link. The reason is we're set up because of using all these herbal prescription antibiotics, we're set up to get too many yeast. Therefore, when things go south, think too many yeast. I mean, that's usually where my thinking is.
Just an FYI, I started on antibiotics, but I didn't last long on that. I had more problems with the antibiotics than I did anything else. So I went herbal quite some time ago, but I struggle on some of the herbs too. I mean, it's just, you know, it's just the way I am right now.
I understand. And you just got to, you can use what you can handle and then do what you can to stabilize the mast cells. And it's a tricky combination. I know it is. Yeah.
Right.
All right. Good luck to you, Bob.
All right. Thank you.
All right. All right. Let's see here. All right. Next question is from AV.
Wait, Marty, I have a quick question.
Yeah. Oh, Meg,
how do you spell ketotifen?
Ketotifen. See, K-E-T, K-E-T, K-O-F. Hold on a minute. I got to look it up.
Thank you.
It has to be compounded.
Okay.
Keto.
So you have to get it from a compounded pharmacy. Okay.
Yeah, because it is made as an eye drop, but you can have the powder and actually make it into a pill. Okay, so it's Ketotifen.
IFE.
So Ketotifen.
Perfect. Thank you.
Yeah. All right, so AV says, hi, Dr. Ross. Can you explain a little about the relationship between Lyme and hypercoagulation and what your recommended course of treatment might be? Thanks. All right. So chronic infections sometimes trigger, as part of an immune reaction, your immune system will start making extra amounts of blood clotting protein, the fibrin, okay? And that can lead to some hypercoagulation. It makes I call it sticky blood. It's thicker blood because you got all these extra amounts of protein, blood clotting protein called fibrin in there. Many of us used to routinely do a test called an ISAC test that would look to see if you have this problem, but I don't think it was always accurate, and many of us just don't do it anymore. If you do have the problem, though, there's a couple approaches you can use. One is you could use Lumbrokinase, which is herbally is probably our best fibrin buster, if you will. And you could start at 20 milligrams one time a day. It's an enzyme that comes from the skin of earthworms. And you could do 1 time a day and then eventually work up to 1 twice a day. That's one option. There are some of my colleagues, I never did this in my practice, but you can use heparin. Actually, you can do injectable heparin to help lower that coagulability as well too. All right, but generally that's what we think it's coming from. AV, did that answer your question for you?
Yeah, thank you. I'm asking for my daughter who actually has had hypercoagulability since she was diagnosed with Crohn's. And I recently just joined your group.
Yeah.
And I mentioned that in my initial say hello post, but she is taking Xarelto right now. She's taking the lowest dose. And,
Okay.
you know,
Yeah.
they think it's connected to Crohn's, but now that I know that she has Lyme, and because they haven't really made a solid connection, so I'm thinking it's coming from that more so.
It probably is, because I'm describing a different problem, which is basically sludgy blood, if you will. If you're using Xarelto, it's a different kind of coagulation problem, basically.
Well, that's the thing. They haven't been able to pinpoint. They don't really know what they're dealing with. So, and she would like to get off of that. And I have heard of Lumbrokinase before, so we had been considering that. Do you think that would be fairly safe for her to transition?
It would be an easy thing to take, which could also be taken at the same time as Xarelto, but I don't know that it's going to be strong enough. If they've had to go to Xarelto, then it sounds like she's had a significant problem here already.
Yeah.
And I don't know, there are no studies that would tell me whether Lumbrokinase will be equivalent to the Xarelto or not.
Okay. All right. Thank you.
Yeah. Good luck. All right, Jim. Hello, Jim. I see you even have your camera on here too. You knew you were coming up. All right. So Jim says, hi, Dr. Ross. Thanks for these great webinars. You're welcome. Let's see, I've just been diagnosed with frozen shoulder. My doctor suggested a steroid shot into the shoulder. Is it okay to do this if you have chronic Bartonella and probably chronic Lyme and other infections? Are there any other things a patient with chronic infection should and shouldn't do when they have frozen shoulder? Also, from the way this has developed, it looks as if chronic infections could have at least been part of what caused the frozen shoulder. Is this possible? If so, does it affect treatment of the frozen shoulder, and would taking collagen or other supplements help? Okay, so Jim, let me just make a comment about steroids and then address your question. Okay, so many of you may be aware, we are concerned when people have chronic tick-borne infections of using oral steroids like prednisone or using injectable steroids that we might give somebody when they're having severe asthma reactions, for instance, or severe allergic reactions, okay? So the problem with systemic steroids like that is they can suppress the immune system, making it easier for the Lyme to take off, even Bartonella to take off, all right? The question comes in, though, when you do get injectable steroids into a joint, for instance, or around the joint, are you getting a lot of systemic absorption or not? And probably not a lot, but you may still be getting enough that can lead to immune suppression. So it's not as severe of a problem if you have tick-borne infections to get local injections into joints or into the tendons and the ligaments, but you may still get enough absorbed into the bloodstream that it could be a problem, okay? So the thing is, if you're working with an orthopedist, orthopedists love steroids. And so when you have a problem, they see everything as a steroid problem. Now I'm being a little bit facetious, but you know, when you go see a cardiologist, they're going to put you on a treadmill. When you go to an orthopedist, they're going to stick steroids in you. It's kind of it's what they do. Okay. But there are alternatives. All right. And so what I would consider doing, Jim, before you go down the steroid route is to negotiate with them and say, look, I got tick-borne infection. It's not a good idea. And so the other alternative would be to start working with physical therapy, to start doing stretches and exercises to get that loosened up. The other thing that can be very helpful for frozen shoulders is actually working with an acupuncturist. Acupuncturists have a good way of using their needling in a way that can often get a frozen shoulder to let go. And so what I would suggest before going down the steroid pathway is I would suggest trying some other alternatives first, which is a pretty good physical therapy stretching out regimen. and then also doing some acupuncture and see if that would make the difference for you. Jim, did it answer for you?
Hold on a sec. Yeah, actually, I think that's good advice. I put a comment in the member-to-member section, and a couple of people responded like it's like kind of an all caps "don't do it" response for steroids because they'd had really bad experiences from it.
Yeah, I agree. If you can avoid it, I would avoid the steroids. That's what I'm saying. Try these other things first before going down that pathway.
Right. I mentioned also in the question, it seemed the way it developed, it looked like the chronic infections might have been part of what caused it.
Yeah.
Is that possible?
Yeah, because they might have led to inflammation within the connective tissue in your shoulder, the capsule of the shoulder, that then, because of that inflammation, developed this frozen nature. So yeah, it could have been under it, but you know, the way to handle that is get your germs under control so you get the inflammation down, but then also start working that joint to see if you can get it to loosen up with physical therapy or acupuncture with that too.
Yeah, for sure. And the other thing was I've been trying the regimen with the methylene blue and the diflucan.
Yeah.
And actually that aggravated the shoulder. That caused like a lot of shoulder pain doing that. So that's part of the reason why I thought it maybe the infection might have been part of it.
Well, you might have had more of a localized Herxheimer reaction, meaning you were getting good killing. Methylene blue is getting in there and killing the germ. And that could have led to more Herxheimer-like inflammation right around there.
A bit too much. Do any supplements help? Does collagen help? Does anything other supplements help?
Not that I'm aware of.
Okay.
Yeah.
Good. Thanks a lot.
You're welcome. Now I see some hands up here. Let's see, Jennifer. What question do you have there, or comment do you have?
Can you hear?
There you are. Now I can hear you. Yep.
I don't have a question. I just wanted to respond about the steroid shot. I don't know if I had Lyme first, but I started having shoulder pain. Went to my primary care doctor and he gave me a steroid shot. And within 5 days, I was in the hospital. My white blood count was over the roof top.
Yeah.
Swelling, knee swelling, joints. Stayed in there 10 days on antibiotics and went home with a PICC line for another 10 days. So I would not get the steroid shot, is my opinion on that.
What I wonder about your situation, though, what you described, especially if the white blood cell count went up that high and you had that much swelling, is if their technique was not clean enough and they caused you to get a joint infection with some germs from on top of your skin that got into that joint. That's what that sounds like.
That could be, you know, because they did it in the office, you know, unguided, no MRI or X-ray or anything like that. But it was a very scary situation.
I bet it was. Yeah.
And one thing too, that this is for everybody. I bought a Life Pro mat off of Amazon. It's a heating mat. I don't know if anybody's ever used one, but I get in that thing about every other day because you know, I don't know how long I had Lyme, but that's when I found out after this hospital stay. The hospital doctors did nothing. They did not test me. And I kept telling them I stay outside all the time. Yeah, I've had animals all my life. I could have gotten bit. But the Life Pro thing, you know, helps me sweat because for a couple of years I didn't sweat. So I don't know if that's a sign of Lyme. I also had vertigo. And since my Lyme diagnosis, I have thyroid issues, I have babesia. It's just, I know everybody deals with their own things, but it's not fun. So
no, it's not at all. Yeah. Thanks for sharing with us here.
Okay.
All right. Lisa, I see your hand up there too.
Yeah, just a quick suggestion for Jim. I had some problems with my knee and my ankle, and I tried prolozone shots. Which is an alternative to cortisone, a natural solution. And I found that to be really, really helpful. So I just thought I would.
It's called prolozone?
Prolozone, yes.
Okay.
Also sometimes called prolotherapy. So prolo means injecting things like saline or lidocaine, maybe even ozone into the tissues, and it causes temporarily more inflammation, which then brings in your white blood cells to heal that inflammation and can give you some healing results. That's a good point, actually. Thank you for suggesting
Yeah,
that.
actually, my doctor mentioned that, the possibility.
Yeah, and that would not suppress your immune system. But I still would, I think that's a good idea. You could even do that up front, but I still would also look at that acupuncture and physical therapy.
Yeah, actually, I have a guy who does acupuncture, but he's about 80, so I hope he's still alive.
And his hand is steady. But anyhow.
Very steady.
All right.
Thanks again.
Tracy, I see your hand up too.
Yeah, I think I think this might be the same person I responded to in office hours, but in case there's anybody on this call who didn't see that, I had a frozen shoulder and I did dry needling. And it reversed it very, very quickly. So getting really good dry needling is kind of the ticket. There are different kinds, and there's a branch where they really work to get a twitch response, so that the muscle kind of contracts. It's not comfortable, but it's phenomenal at how helpful.
So I kind of look at dry needling comes more out of physical medicine, but I put it still within the realm of acupuncture. It's the same, a little bit of a different offshoot, but still it's the idea of sticking needles in. There's some healing that happens from doing that, basically. Yeah.
Right.
Thanks, Tracy.
Mm-hmm.
All right, let's see here. This is somebody on an iPad, and I can't tell who it is, but it says, "Hi all, Dr. Ross. Wayne is," oh, it's Wayne. Hi, Wayne. Let's see. My question is about mold's relationship to Lyme. Just diagnosed as Lyme positive 4123 present, IgG 58 present, as well as having Marcons. I'm not clear whether to do further tests to confirm that I do indeed have Lyme, or to accept these first LabCorp positive tests, or to start treatments immediately for Lyme and or mold. My LMD has suggested Lyme N or doxycycline for Lyme treatment, and Beg spray or silver EDTA for Marcons. Okay, let me try to address this with you. So I'll share a story with you, and this will be a quick. And my intention, just Lonnie, I intend to get to your question here eventually, just so you know. Okay, so don't worry. I know you've been wanting to get me to answer that for a little bit, but I'll get to it in a minute. All right, so you can have Lyme and you can have mold. You can have positive testing for Lyme and you can have mold, but the positive testing may mean you had an old infection for Lyme that your body dealt with, and what you really have is mold. All right, so let me give you a story. So when somebody comes to see me, and or at one time I had a patient that came to see me. He was brought in by his mom, who is a nurse. He was mid-40s. He basically was so ill that he couldn't think straight anymore. He'd lost his job. He lost his family. He lost everything. And bad body pain, you know, the whole story of everything bad. He had it bad, all right? And he had a positive Lyme test and was brought in had been seeing a naturopath in town that had told him that she thought he had severe neurolyme, and if he did not get on IV antibiotics right away, he was going to die, and that he needed to go immediately out to Washington, D.C. to see Dr. Jemsek, who was going to take care of him by sticking IV needles in him and getting IV antibiotics going. And his mother, as a nurse, thought that doesn't make sense. That doesn't totally fit everything here. So brought him to see me. All right. So when I looked at him, I acknowledged he had a positive Lyme test, but one thing I always do when I see a patient is get the story of what happened and when it happened, okay? And as I was getting his story, it became clear to me that we may have a mold problem, actually, because he was doing well. He had been bitten by a tick years ago, but was doing well. And then and I always ask people, before you got sick, did you just move into a new building, or did you have water damage that you discovered all of a sudden, something like that? And he said, well, yeah, I just moved into this new house, and within 2 weeks, I was severely ill. So tell me more about that house. And what we discovered is he had the old renters that were there before him had a big aquarium in the back, and there was mold on the back walls of the house. And so his story said to me, go after mold. And so I tested him for mold toxins with a urine test, and his urine mold toxin tests from real time came back with about everything sky high, basically. Now, I acknowledged he had a Lyme test and all of his symptoms looked like they could be Lyme, but keep in mind mold toxicity, because it also triggers excess cytokines like Lyme, can look just like Lyme. And his story said, I got sick when I moved into mold toxins. That's what his story told me, okay? So all I did for 6 months was I used binders to pull mold toxins out. And at the end of 6 months, he was 100% well. And we never did anything to treat for Lyme infection. And in his situation, I think that his antibodies that were showing up were probably an old infection his immune system had dealt with, but his current problem had nothing to do with Lyme. Okay, so I just want to let you know that is a possibility. So the first thing I always try when somebody has mold and also positive Lyme tests is by history, try to determine if you can detect that maybe it's mold that set the whole thing off. And if it is, go after mold toxicity first. That's the one thing that I usually suggest to people, okay? If it's not clear and you've got both going on, then often what I will do is I'll start to treat for the Lyme infections first. And a few months into treatment, I might start adding things in to bind up those mold toxins and pull them out. All right, that's kind of the approach that I wind up doing. You can do both at the same time, but because you don't want to trigger too much excess cytokines, you don't want to start binding and pulling toxins out at the same time you're killing all these germs, you may get into cytokine overload. So I usually stage it. When it's not clear to me, I'll stage it by treating for the Lyme infections or tick-borne infections first, get them stabilized for a few months, after a few months, then go in and start the binders to pull the mold toxins out. Okay, all right. Now, I want to say something about Marcons. I think Marcons is not a real condition or something to worry about. And let me explain why I'm saying that. Okay, so the person that discovered mold toxicity is a physician named Richie Shoemaker. And Dr. Shoemaker has developed this whole elaborate condition that he calls chronic inflammatory response syndrome, which is something he says develops after you first get mold toxins. And what happens is, in his theory, is you get mold toxins that get you all inflamed. And if you do binders and you don't get better, then in his theory, he starts looking for other things that keep you chronically inflamed. Okay. And his second step is swab the nose, look to see if you have this bacteria called Marcons in your nose. And if you do, he theorizes that that's the reason that you are still sick and you got to kill that Marcons. All right. Now, keep in mind, Dr. Shoemaker does not believe in chronic Lyme as a cause of why people are chronically inflamed. All right. So he keeps looking for all these other reasons they stay inflamed instead of the big elephant in the room for most, which is they have chronic Lyme going on. All right. So he just ignores the chronic tick-borne infections. All right. But because he's looking for a cause, he discovered this Marcons. All right. So here's the deal with Marcons. If you do get rid of it, most of the time, 99% of the time, people do not get any better when they have tick-borne infections, okay? All right, so I used to treat it. I just never found that it made any difference to anyone to clear it, all right? Secondly, it's damn near impossible to keep it away. Once you clear it, it'll come right back. And the reason I think happens is, and it doesn't matter what you use, whether it's the beg spray or use beg spray with the prescription antibiotic rifampin, it's going to come back. So people like Dr. Neil Nathan, who also writes a lot about mold toxicity, no longer treats for Marcons either. He and I have had discussions about this. And our opinion, my opinion, his opinion is it's probably a bacteria that just happens to be colonized in some people. It's probably not the cause of anything. All right. And so, but I want to clarify something. Marcons is not a fungal infection. All right. It's a bacteria that lives in your nose. And so because it cannot be cleared, and because most of us that treat tick-borne infections that have tried to treat Marcons, we found it didn't make any difference to clear it. Most of us that treat tick-borne infections do not do anything about Marcons anymore. And so I just throw that out. So I'm not sure why your provider is doing that, but that is not where I would go with things, basically. All right.
Thanks, Dr. Ross.
Yeah. Did that answer your questions for you?
Yeah, absolutely fantastic. Thank you. And just another point for me is about a year ago, I had a massive tooth infection, had to have the tooth pulled, had huge sinus issues after that. And this led to dizziness and all the things I'm experiencing right now. And in going to the doctor, I discovered the Marcons and the Lyme.
I would probably focus more on the Lyme. Also, I think it's a good idea to always look to see if you have mold toxins in you, and that would be to do a urine test to see if you have them in you, called a real-time test.
Right.
I don't, again, I just have never found benefit from treating for Marcons. Even after I clear it, people don't get better from that.
Do you then recommend the doxycycline as the way to go?
For the Borrelia, so if you're talking about how to treat Lyme,
yes,
where I would, it is a place to start, but by itself, if you have chronic Lyme, it probably will not be enough by itself. What I would suggest you take a look at to figure out what you need to address, take a look at my Lyme information site, Treat Lyme by Marty Ross MD. There's a tab at the top called the Ross Lyme Support Protocol. Look through that. It talks about key steps you should take in recovering, like lowering cytokines, using ashwagandha. But there's a section about where do you start on a Lyme germ treatment. And I give you both herbal and prescription options. They're both designed to cover all three appearances of the germ. So Borrelia lives as a spirochete, it lives inside cells, and it also has a microscopic cyst form. So you want to treat for all three. In addition, we recognize those three different forms can either be growing or hibernating. We call those hibernators persisters. And so when you design a treatment, you want to make sure you're designing to cover all three forms and the two growth states. Doxy is only going to go after growing spirochetes and growing intracellular. It's not going to do anything for cyst, and it's not going to do anything. Yeah, that's it. So it's not going to hit the persisters. Okay, so rather than taking time to go through all what those would be now, take a look at my protocol. I give you an idea of where to start, so you cover
Will do.
all. Okay, all right.
Thank you, Dr. Ross.
You're welcome. Good luck to you.
Thank you.
All right, let's see here. Hello, Brenda. Let's see. Hi, Dr. Ross. Is EBO therapy an effective treatment for chronic post-Lyme disease, various co-infections? Is this an effective treatment for those dealing with neurologic issues? Can you tell me what you mean by EBO, by the way?
Hi, Dr. Ross.
Hello, Brenda.
I'm talking about the oxygen therapy, where it's IV, the double IV with the ultraviolet.
Okay, yeah. So EBO is another, what I will call oxidative treatment. Okay, so oxidative treatments are ozone, hydrogen peroxide. You could do hyperbaric oxygen. You could do IV. You can do radiation, UV radiation of your blood. These are oxidative therapies, okay? And oxidation can kill germs. But the main reason that people probably feel better on oxidation therapies is they result in better oxygenation of your mitochondria, your cell energy factories. And so people will feel better, all right? But because you get better energy production. However, these do not appear to be effective ways of killing your germ load. We've just years of trying this stuff, I've never found these to be the things that result in people getting better. They feel better because they're getting better oxygenation of their mitochondria. But in terms of something that's going to really be effective at reducing your germ load, none of these oxidative therapies are good to do that.
Not even in conjunction with other therapies?
You know, you could use it in conjunction, but I think what you're really benefiting is you're getting your mitochondria to work better. I don't think they're germ killers, though.
I have a very complex history. I happened to come across some medical paperwork back in 2013, 2014, where they said that they tested me for Lyme, but I didn't have all the bands, so they didn't consider me being Lyme positive. But I had co-infections like typhus fever, spotted fever, Coxsackie, mycoplasma. And in 2020, I really didn't have appropriate treatment. I was reinfected. It showed maybe a test that I may have been reinfected. And then I had a vibrant test, so originally I tested for P41, then now I tested for P41, P58, Borrelia, the Coxsackie's, Epstein-Barr, parvovirus, B19. I have a whole lot of co-infections, and as you could see, I have a difficulty, the air hunger.
So I hope, are you working with somebody that understands all these infections and other words of Lyme literate doctor at all, or not?
I am open to finding someone because I really do need treatment. I need some help right away.
Because what I would describe, this forum is not going to solve your problem. For instance,
Right.
I mean, I can't provide that kind of medical care for you here. But what we do know is when people have complex situations, like there's some research that tells us when you have these chronic infections, one of the things that will get you well is if you have a good physician helping to guide you that understands these things. So I don't know where you live, but I mean, a starting point is to look at, go to ilads.org. And they do have a place on their website where you can put information in to help locate people near you.
Yeah, right.
Okay. Good luck to you. Yep.
Thank you. Thank you.
I don't want to go into how awful they were, but they let that be enough said.
All right, so let's see here. Rid of that here. Hello, Susan. Let's see. Hi, Marty. Can the sublingual essential oils be substituted for methylene blue for persister cells when using azithromycin and hydroxychloroquine and metronidazole flagyl? So, the methylene blue, what it does is we think it is, or there's lab evidence that shows it's very useful at killing persister Bartonella and persister Borrelia, so the hibernating state. Lab studies also show us that it's very useful against growing Bartonella. There is no lab evidence or lab testing that's been done to show that it does anything for growing Borrelia, but most of us that work with it think it's hitting growing Borrelia as well too, based on what we see in terms of response, okay? The other action of methylene blue is it's great at breaking up Bartonella biofilm, all right? So if we compare that then to the action of essential oils, and predominantly I consider those essential oils that have been studied to be oregano, clove, cinnamon, garlic oil would be in there too, but there's lab studies out of Hopkins that say these essential oils are good at treating growing and persister Lyme and Bartonella. In addition, there's data that says they break up biofilms, all right? So in theory, methylene blue does the same stuff that the essential oils do, all right? What I cannot tell you is, are they equivalent in every person? So in some people, I see stronger reaction and stronger action, stronger benefit using methylene blue. In other people, I see stronger benefit, stronger action and using the essential oils. And so I can't tell you which is better. What I can tell you is, yeah, that sounds like a reasonable substitution. Try the essential oils, see if you get benefit. It's doing the same, it's handling the same issues that methylene blue would handle for you, basically. Okay. All right. Did that answer your question?
Yes, thank you. My daughter's 14 and she just got her third diagnosis via Western blot for Borrelia. And yeah, so she had the classic symptoms at age 6 and we had a really hard time getting her treated. And then getting her tested, and by the time she got tested, it was late stage. And
Yeah.
She did see an LLMD back then. However, that person was also sick with Lyme and they ended up retiring.
Yeah.
She was fine. We ended up doing herbs back then, and she was fine until 2 years ago. She had what I believe is a flare up. We've been very careful. We don't believe she had a new bite.
Yeah.
But she did have another positive then. She did doxycycline and she was okay until, like I said, that was 2 years ago. Just a little over a month ago, she started having severe spinal pain, unable to sit during classes. And,
so one thing
we had her tested again, and this time she's positive again. So she started the doxycycline, but her stomach issues, the side effects were too severe to where we wanted to try something else.
Let me give you a quick tip to think about.
Sure.
Okay. All right. So once you have Lyme, your testing may remain positive forever. So having positive testing does not indicate that it's newly active again. All right. Right. So when you get worse, it's valid to think maybe my Lyme is active. But what I have found in people that have been previously treated with herbal or prescription antibiotics, about 80% of the time, what looks to be a relapse is not. It's actually due to too many yeast starting to grow in the intestines. All right.
And what do you normally use to reduce yeast?
Yeah, so let me just finish that point. So,
sorry about that.
Is when you have chronic tick-borne infections, one of the big reasons you feel badly is your immune system makes too many cytokines, and it's the excess cytokines that give you most of your symptoms. And if you get too many yeast in your intestines, guess what happens? You make too many cytokines, and it makes it look like all of your tick-borne infection symptoms are back. Okay, so that's why I'm saying that. Okay, so I would look at, I'll show you what you can look at here in a minute, but I have an article on how do you diagnose if you might have too many yeast. It's based on symptoms. All right, and then I have an article that says what do you treat it with. From a prescription standpoint, my favorite is to use a combination of nystatin and diflucan along with probiotics. Okay. And let me show you the article where you can get more of the details on that. Okay. Let me do a screen share here. All right. So take a look at my information site here. And I have a chapter that I've organized called Yeast. And about how do you diagnose based on symptoms, take a look at this one called a silent problem. Is it yeast? Okay. And then for different ideas on how to treat, I did just mention the nystatin, diflucan, it's in here. There's other ideas too, but take a look at this article called Kills and Prevents Yeast, a brief guide, okay? But it may not be a yeast situation, but I tell you 80% of the time I have found in my patients, if they came in and they had what looked like a relapse, if I took a history and it sounded like there was any chance it might be yeast, I would treat yeast, and 80% of the time that took care of the problem for them.
Amazing. That's really amazing. Thank you.
Yeah. Good luck to her.
Thank you.
You're welcome. All right. Let's see here. Hello, Lonnie and Ann. All right. Let's see. It's Lonnie. I have medication change questions about my daughter. She was tested by Vibrant and has the 3 Bs as well as prior to traumatic brain injury. 3 times she's had COVID, tested for tick-borne disease 2023, multiple symptoms, treated for BART and Babesia per your protocols in April and September. Can she take rifabutin, itraconazole, methylene blue, malorone azithromycin? She's on multiple other meds secondary to prior tick-borne or traumatic brain injury. TBI can mean tick-borne infection too, by the way, but I know you mean for your daughter traumatic brain injury. She can change azithromycin to clarithromycin. How to address low H&H and red count. Okay, so the problem I have with using rifabutin and itraconazole together is that both have the ability to lead to liver inflammation.
Okay.
So I'm usually very cautious about using that combination unless I don't have another choice but to try it. So if you are going to do that, I would probably look at doing maybe initially every week to 2 weeks, checking your, your liver function tests just to make sure she's handling it okay. The other thing I would do if you're going to do that combination, I would look at making sure she's on glutathione at the same time, because glutathione is going to help calm that liver inflammation down, basically, right? So you're going to assume she's probably going to get a little bit. And then in terms of the liver inflammation, so everyone, Lonnie's a physician, okay, so I know that, but I want to explain, Lonnie, I want to explain something to everyone else. So when we're looking to see if you have liver inflammation, we're measuring two liver enzymes, something called AST and ALT, all right? And I assume with many of our antibiotics, we're going to get a degree of liver inflammation. And I don't let a small amount of liver inflammation stop me from using those antibiotics. What I have done in my practice is I accept you're going to get liver inflammation, but I don't want it to go above 2 times the upper end of normal range. So what I mean by that, Lonnie knows what I mean, but what I mean by that is normally like AST, ALT, or range, depending on which lab, it's going to be 20 to 40 is usually a normal range, right around 20 to 40, okay? And so you would not want to go above 80 on your AST or ALT if you're, and every lab's a little bit different, but on average, it's 20 to 40 is going to be your range on your AST and ALT, all right? And I would get on a teaspoon of that Trifortify liposomal, the liposomal, Trifortify liposomal glutathione, which is made by Research Nutritionals. The reason I love their product is they got data showing great absorption, and it really did. The blood cell levels go really up high when they've measured it. There's some other indicators they've done research on it show that it's getting absorbed too. A lot of your glutathiones are just not well absorbed, but that product is. And I would do about a teaspoon a day on that. Okay.
We've been using it for about the past 6 months.
Good. So that's going to give her some protection. But I would be cautious. I would do like every 2 week AST ALTs. If you do that like 3 times and she's looking fine, then you may want to switch out to once a month and just follow from there. Just because those two sometimes do have the ability to inflame the liver, basically. Yeah.
Would you do the rifabutin twice a day or 3 times?
You can do rifabutin once a day, actually. Now, the reason I will split, so rifampin and rifabutin are in the same family. They're part of the rifamycins.
We had side effects from rifampin, so we had to go to the rifabutin, but we only tried it for a couple of weeks, and then I had consulted you, and we decided to push that aside for the time being and go back to the itraconazole when we added the melanoma.
So you can do rifabutin as well as rifampin. You can either both of those twice a day or once a day. My preference is to do once a day just because it's easier to get it all in at one time. However, in some people, taking it once a day gives them nausea, in which case splitting to a twice a day with your daily dose will help take care of that nausea.
Okay.
Okay.
If we did have to stop the itraconazole, what would still cover the BART?
So you've got good coverage. So the methylene blue would be, along with azithromycin, is a good BART treatment, actually. If you look at the Johns Hopkins data from a few years ago, I think Anne shared with me earlier today that article. That article suggests, I think it was that article that suggested, says that your 2 strongest methylene blue combinations are methylene blue with a rifampin in their study, which rifabutin would do the same, or methylene blue with azithromycin. Those were their 2 strongest combinations in the lab at removing biofilm, getting at growing and persistent Bartonella. So your methylene blue with azithro is a good combination. But if you want to throw a third agent in, if you can't do the itraconazole and you want to put a third agent in, I would be looking herbal, actually. I would be looking at either this liposomal cinnamon clove oregano.
We're on that also.
Okay. You already on that one right now?
Yeah, the LCCO.
Yeah. Yeah. So you've actually got, that's a great regimen. You're already on a good regimen, basically.
Okay. Oh, that's because I read some good articles from a guy named Marty Ross.
Yeah.
Noser.
I wouldn't listen to him.
I do. So far.
All right, Lonnie. Good luck with your daughter.
Thanks.
All right. Let's see here. What time? 7:30. I'm going to do one more. I'll take a question here from Nancy. Hi, Nancy. Can taking B12 and other B vitamins make you feel bad, such as pretty severe headaches? So the answer is, this is my theorem or my rule in the Marty Ross rule. Okay. The Marty Ross rule is this: anything can happen to anyone with anything. All right. So there are what we call the common side effects. You can open up a drug directory on any drug and you would see the common side effects. But that doesn't mean those are the things that happen to people. Some of us have our own unique side effect reactions. And so I would not say that what you're describing with B12 is common, but in your situation, it sounds like it does. And so, yeah, that's the best I can say for that. I don't have a solution for you, unfortunately, though, but I think it's your unique reaction, it sounds like. All right. All right, everyone. That is it for me for tonight. I'm still trying to decide what to do with next week. Next week is Wednesday, and I plan on, it's the 4th Wednesday. And so for the 4th Wednesdays, I do a morning webinar, but it's also the day before Thanksgiving, and I'm not even sure if we're going to have adequate turnout. Plus, I'm going to be on the road with my dad, who is in assisted living and a nursing or an assisted living, and I may have my hands full. So I'm trying to decide. I'll let you know. And then I say, but I may take off next week because of the holiday and dealing with dad. So, but I'll let you know. Okay. I'll figure that one out by tomorrow morning. Okay. All right. All right, everyone. Take care. Watch for the tomorrow morning sometime, hopefully before about 10. I should have a summary up and the video up for you as well too. Okay. All right.
Bye, Marty. Thank you.
Yeah. Bye, everyone.
Thank you, Dr.
You're welcome, everyone.